We just have everyone's attention for a moment. They have called a vote on the floor. As you can see, the minority has not yet shown up, so we will have to delay the start of this hearing until after the rule vote on the floor. But a rule vote is an extremely important part of the work that we do here, Mr. Shimkus. But I also want, for members of the majority side who are here, and I appreciate the fact that you're here, we will recognize the fact that even though the gavel will not fall, we'll recognize the fact that you were here on time as far as the order for questioning. Except for Billy Long, that's correct. So since I haven't gavelled in, I don't need to adjourn. We'll just go vote, and then we'll come back and gavel in after the first series of votes. Oh, my goodness. You are here.
Strike everything you just said.
I haven't gavelled in. All right, change of plans. Please take your seats. Subcommittee on Health will now come to order, and I've recognized myself for 5 minutes for an opening statement. Today's hearing is one that has been in the works for quite some time. As many of you know, this hearing has been rescheduled twice, but given that we've now enacted important technical changes, providers having information on their first performance year and this year's quality payment program rules to discuss, this hearing is timely now. I'm glad we can complete our due diligence as members of the Health Subcommittee and conduct oversight and the implementation of the Medicare Access and CHIP Reauthorization Act of 2015. This bill, which came through the 114th Congress, the product of careful, intricate bipartisan negotiations, and was passed by both chambers of Congress with broad support. Signed into law on April 16, 2015, this bill repealed the sustainable growth rate formula for all time. The sustainable growth rate formula was for calculating annual updates to physician payment rates under Medicare. We now know that the formula, which was enacted as part of the Balanced Budget Act of 1997, turned out to be unwise. As an OB-GYN prior to coming to Congress, I was frustrated with the annual exercise of the sustainable growth rate formula, as were many other physicians, as were members of Congress. I would like to take a moment to remind members of what the world of physician payments looked like before the repeal and before the passage of the Medicare Access and CHIP Reauthorization Act. Congress consistently passed legislation to override the SGR. That resulted in hundreds of billions of dollars spent that could have gone to bolstering Medicare and other health programs. Medicare providers and their patients, by extension, were under the constant threat of payment cuts under the sustainable growth rate formula. The formula's unrealistic assumptions of spending and efficiency have plagued the healthcare profession and our Medicare beneficiaries for a long time. The Medicare Access and CHIP Reauthorization Act repealed the SGR, provided for statutory updates to allow improved beneficiary access, and got medicine to concentrate on moving to broad adoption of a quality reporting system. One of the most important provisions in the law was a shift from a fee schedule system towards a merit-based incentive payment system. The law left behind a pass-fail quality reporting regime whose measures were too often set up against a one-size-fits-all generic standard of care with no financial upside for providers. Since the merit-based system was set to go into full effect on January 1st, 2019, the first payment consequence year from reporting provided in 2017, it is critical that we hold this hearing and hear from our witnesses and assess what's working, how the transition is progressing, and where improvements have been made while seeking ways to simultaneously encourage stronger participation and reward providers already invested in the MIPS track. The Medicare Access and CHIP Reauthorization Act required the Secretary of Health and Human Services to establish a methodology to assess this merit-eligible practitioners and give each one a performance score which determines payments based on a scale of 1 to 100. In the first year, the performance benchmark was set at 3. This year, it was set at 15, and the Center for Medicare and Medicaid Services recently proposed raising it to 30 for 2019. The merit-based incentive payment system incorporated specific performance categories, including quality, resource use, clinical practice improvement activities, and meaningful use of electronic health records. The eligible population was also set to change over time, and the Centers for Medicare and Medicaid Services recently proposed to add a slate of additional providers to the program. Overall, stakeholders and physicians have been supportive of the transition. In our third hearing, we heard from providers getting the benefits of savings by participating in the Advanced Alternative Payment Model. That said, the Medicare Access and CHIP Reauthorization Act was a long-term project and a viable fee-for-service model in the form of the merit-based incentive payment system needed to exist. In continuing to follow the Medicare Access and CHIP Reauthorization Act implementation, certain decisions were made by the Center for Medicare and Medicaid Services that were for the benefit of a smooth transition, but had consequences that affected the agency's trajectory of setting the performance threshold. Given this and other developments, I believe that the law would benefit from some technical updates to improve the implementation based on real-time factors. The Bipartisan Budget Act of 2018 included 3 technical fixes. This was done by myself, Ranking Member Green, and Representatives Roskam and Levin from the Ways and Means Committee. The Medicare Access and CHIP Reauthorization Act changed the world of Medicare provider payments. It has laid the groundwork for increased access to quality care for beneficiaries by eliminating the uncertainty of the past, reducing physician burden, and providing incentives where previously there were none. It was never a law that was going to be fully implemented with the flip of a switch or a signing ceremony. It was designed as a long-term effort to move the Medicare program down the value continuum. So once again, I want to thank our witnesses for joining us today. Look forward to hearing from each of you about how the implementation of this important law is progressing. Yield back the balance of my time and recognize the ranking member of the subcommittee, Mr. Green, 5 minutes for an opening statement.
Thank you, Mr. Chairman, for holding today's hearing on the Medicare Access and CHIP Reauthorization, MACRA, and the Merit-Based Incentive Payment System, MIPS. I also thank our esteemed panelists for joining us this morning. The sustainable growth rate, SGR, was a thorn in the side of Medicare and doctors who treated Medicare patients for over a decade until it was, after it was created in 1997. SGR's formula led to a reduction of physician payments starting in 2002 that had to be patched annually by Congress. In 2014 and 15, our committee, along with other committees in jurisdiction, came together and passed bipartisan legislation, the Medicare Access and CHIP Reauthorization Act, which permanently repealed the SGR. MACRA did more than just repeal the flawed SGR formula. It was designed to overhaul and realign payment incentives for Medicare and transition of our health system to one that rewards value instead of just the volume of care. MACRA provides stability to Medicare payments for providers for the years immediately after the enactment and in more easier for providers to report on and deliver high-quality care. Critically, MACRA encourages providers to move away from fee-for-service and participate in a new delivery model that would reduce cost while increasing quality. Under the law, physicians who treat Medicare beneficiaries have a choice between participating in MIPS or the Advanced Alternative Payment Plan, APMs, to make the shift from fee-for-service and volume-based payment system to a value-based payment system. MIPS streamlined 3 prior quality incentive programs that were sunset in 2016 and have been replaced by new MIPS category: quality, improvement activities, meaningful use, and cost. Since starting in 2017, healthcare providers could choose whether to participate in APM or MIPS. Providers are exempt from MIPS if they fall below the low volume threshold. For 2017, the Centers for Medicare and Medicaid set the low volume threshold for providers who see fewer than 100 Medicare Part B patients or have less than $30,000 in Part B charges annually. For 2018, CMS increased the low volume threshold to $90,000 in Part B charges or fewer than 200 Medicare patients per year. And for the next year, CMS has proposed maintaining the low volume threshold for MIPS while adding a third exemption route for clinicians providing less than 200 covered services. CMS has provided proposed allowing clinicians meet the exemption criteria to opt into MIPS. Under MACRA, Department of Health and Human Services is required to set the performance threshold by 2019 at the mean or median of final scores for all MIPS eligible clinicians. In February, Congress passed legislation changing the timeline to ease the burden of the MIPS transition. The Bipartisan Budget Act of 2018 granted HHS an additional 3 years to ensure a gradual incremental transition to the mean or median performance. I look forward to hearing from our panelists regarding their experience with MIPS and recent changes made by Congress, whether additional actions necessary to ensure physicians participating in MIPS is generating savings in Medicare care and improving patient outcomes. Thank you, Mr. Chairman. I yield back my time. Nobody on our side, so I don't think they want any time.
I thank the gentleman for yielding back. Gentleman does yield back. The 3 minutes left on the vote on the floor. We are going to recess until immediately after the vote on the floor. call the committee back to order. We are still waiting on the return of the ranking member and the chairman of the full committee, but anticipating that they will arrive. And let's thank our witnesses for being here today and taking time to testify before the subcommittee. Each witness is going to have the opportunity to give an opening statement, followed by questions from members. Today, we'll hear from Dr. David Barb, the immediate past president of the American Medical Association, Dr. Frank Kopelka, Medical Director, Quality and Health Policy, American College of Surgeons, Dr. Ashok Rai, Chairman of the Board, American Medical Group Association, Dr. Parag Bareka, American Society of Cataract and Refractive Surgery, and Kurt Ransoff, Chairman of the Board, American Physicians Groups. We appreciate you being here today, doctors. And Dr. Barb, you are now recognized for 5 minutes to give an opening statement, please.
Chairman Burgess, Ranking Member Green, and committee members, thank you very much for the opportunity to come here today and to update you on the continuing implementation of MACRA. I am a practicing family physician from rural southern Missouri, actually in Congressman Long's neck of the woods, and as you say, past president of the AMA. You know, physicians are familiar with value-based payment mechanisms. We have been subject to those for over 10 years, starting with PQRI, which was the original quality-based program. That was in 2007. Meaningful Use came in 2009. Value-based payments began in 2013. But each of these programs came in at separate times under separate bills, were never harmonized, never even contemplated working together. And all of them started as incentive programs, but most of them have transitioned into penalty programs, which are additive. And as of now, a physician who is not able to perform for whatever reason in those programs could be subject to up to 11% negative adjustment in their Medicare reimbursement. That was simply not sustainable, and we thank you and the others that worked so hard on MACRA in 2015. That is a significant step forward. Not only did it repeal the SGR, as has been noted, but it began to harmonize these programs, bringing them under one administration, if you will, and it also reset, very importantly, the incentive and penalty corridor such that for performance in the first year of 2017, it was a plus or minus 4%. Certainly a better opportunity for physicians to succeed under that particular framework. So we appreciate the work that went into that. We share a common goal with you in seeing that this program, these new quality payment programs, are implemented appropriately, that the transition is smooth, because we believe that the success of these programs has a real opportunity to improve quality for patients, to bend the cost curve. But for them to be successful, physicians have to be able to succeed under these programs as well. And again, MACRA took us a significant step toward physician success and improving these programs. In your opening remarks, you mentioned the BBA 2018 and the significant improvements and technical fixes that were made. We really appreciated those as well. We will continue to work closely with you because, as you also suggested, this wasn't a one and done. This is an evolving process. And hearings like this today, allowing us to update you, are critical in continuing to improve that process for patients, for physicians, and for the Medicare program. As a part of the BBA 2018, we strongly support the Part B drug cost exclusion. We support flexibility for CMS to reweight the cost performance measures. We appreciate the performance threshold flexibility that you gave CMS. We need now for CMS to use the flexibility that you gave them to make this transition appropriate. So we will continue to work with them. We have made multiple suggestions already, and we'll continue to try to make this transition appropriate. One of the other pretty important parts of what you enabled was for PTAC to consult with physician groups as we develop physician-focused payment models. The PTAC has been doing what you've wanted it to do. They have received dozens of proposals, and they have even recommended about 10 of those onto CMS. Unfortunately, CMS has not seen fit to adopt any of those yet, and I think it is thwarting the creativity and innovation that physicians are willing to bring to the table. So we will continue to work with CMS to try to get them to consider and adopt some of those alternative payment models that are physician-focused that PTAC has recommended. And I think lastly, you may hear some discussion today about the limitation of the upside opportunity to something in the 2% range rather than the 4% that was originally contemplated. Again, the goal is to help physicians succeed. All of the organizations represented here represent a wide range of physician practices, physician styles. The AMA certainly does. We represent physicians from all specialties, all practice types. It is critically important that all those physicians have an opportunity to succeed under this program, whether you're a large mega group like the one I'm in, or whether you're a single independent physician, practicing, someplace else in Missouri. You need an opportunity, and so CMS needs flexibility. We need a smooth transition, and we really appreciate the continued opportunity we have to dialogue with you on this.
Thank you, Dr. Barb. Dr. Pelko, you're recognized for 5 minutes, please.
Chairman Burgess, Ranking Member Green, members of the committee, on behalf of the 80,000 members of the American College of Surgeons, we appreciate the invitation to share our thoughts with you today. The American College of Surgeons again expresses our thanks to Congress for the aspects of MACRA which have eliminated the sustainable growth rate and led to efforts designed to link payment more closely to quality and value. Congress's efforts have not only reduced maximum penalties, your efforts seek to phase in new incentives and provide potential for positive updates. Particularly noteworthy are the congressional efforts to combine and simplify value-based goals for measuring quality and improvement. After all, we measure so that we can improve, not just get paid. We also appreciate the congressional directives for moving from fee-for-service to alternative payment models. We would wish CMS would improve their efforts to work with the American College of Surgeons ACS physician-focused payment model. We are mindful of Congress's interest in oversight of CMS's implementation of MACRA. In order for clinicians to assume risk in value-based payment programs, physicians must have reliable and valid measures of both quality and the cost of care. The American College of Surgeons seeks to support the congressional intent of MACRA through our work product for building meaningful quality measures for surgical patients and surgeons, as well as proffering to CMS our APMs, which are based on true total cost of care. The American College of Surgeons began over 100 years ago, when America had more hospitals than we have today. They were small, and care was not standardized. To standardize quality, we formed the College of Surgeons, and we created the first hospital accreditation. In later years, this became the Joint Commission. Today, we continue those verification programs in order to promote standards for quality of care in trauma centers, such as Level 1, Level 2, and Level 3 trauma centers. Neither the federal government nor commercial payers do much to recognize the over 200 quality standards we create to maintain a national trauma system for this country. Our verification programs are a model which measure what matters to patients. We measure the team and the totality of care. We worry less about measuring the individual surgeon and focus more about measuring the outcome to patients. We then credit the entire team with its successes, and we use the knowledge gained from our programs to create learning networks which teach others and spread improvement widely. None of this recognized in payment programs. In much the same way, we've created cancer verification, breast care verification, bariatric care, pediatric surgical care, and now more. Yet CMS offers meaningless measures which do little to help the surgical patient. CMS feels constrained from measuring team-based measures, instead seeking simply constructed measures, such as surgeons having to track patients' immunizations, rather than measuring the surgical team. The end result is measures become meaningless, burdensome, and distractions. Hospital CEOs end up defunding valued surgical quality programs to chase the wrong measures, simply because that's how they get paid. It's time we, as the American College of Surgeons, seek congressional directives for CMS to build a strong surgical quality program for each major surgical domain, just as the college has done in our team-based models for hospitals, for trauma, for cancer, and more. It's time that we measure what matters. It's time for payment models to align with clinical care and not force clinical care to conform to payment. Lastly, the American College of Surgeons serves as a leader in digital information and health IT. We are focused on patient-centered digital records, not just EHRs, since patients' lives exist in more than one EHR. This calls for an expansion of our thinking beyond EHRs into a world of interoperability, connecting patients across EHRs, across smart devices, across clinical registries for activities such as clinical decision support, machine learning, and artificial intelligence. There is so much more we can do for quality and for lowering cost by leveraging digital information. We have to stop thinking of EHRs and think beyond them. We could use your support in promoting this level of interoperability to make an interoperable digital patient medical record. We look forward with working with the Congress to help surgeons care for patients. Thank you very much.
Thank you, Doctor. Dr. Rao, you're recognized for 5 minutes, please.
Chairman Burgess, Ranking Member Green, and distinguished members of the Energy and Commerce Committee on Health, thank you for the opportunity to testify today. I'm Dr. Ashok Rai, and I'm here today as chair of AMGA, which represents multi-specialty medical groups and integrated delivery systems. Our membership provides care for 1 in 3 Americans. I'm a board-certified internist with 17 years of experience providing care to patients in Green Bay, Wisconsin. Since 2009, I have served as the president and CEO of Prevea Health, a multi-specialty medical group which employs more than 350 providers, including 60 medical specialties. In total, we employ more than 2,000 people, and I'm proud of the impact we have on the people of Wisconsin. I wanted to express my appreciation to Congress for repealing the SGR formula for Medicare Part B payments. The annual SGR cliffs were obstacles to sound planning and hindered our ability to make strategic decisions that would help us care for patients. I applaud the committee's leadership role in passing the much-needed MACRA law, which puts providers on path towards value-based care. We agree with Congress that the current fee-for-service payment system is not sustainable, nor is it good for our patients. We need to move to a system where the payment aligns with the way medical groups focus on the health of a population rather than only the sickness of patients. Under MACRA, CMS combined existing programs such as the Physician Quality Reporting System, the Value-Based Modifier, and Meaningful Use programs to create the Merit-Based Incentive Payment System, better known as MIPS. Under the MACRA statute, MIPS providers would have the opportunity to have positive or negative payment adjustments based on their performance, starting at plus or minus 4% in 2019 and eventually plus or minus 9% in 2023. By putting provider reimbursement at risk, I believe Congress intended to move Medicare to a value-based payment model where high performance was rewarded and poor performers were incented to improve with lower payment rates. In fact, high-performing groups like Prevea Health have been preparing for this value transition for years by participating in MIPS legacy programs such as PQRS, VM, and MU. As a result, our efforts to perform in these legacy programs have improved the value of care provided through increased quality and decreased cost. But the problem we face now as healthcare providers is that CMS is excluding a majority of providers from the MIPS program. CMS has bypassed the intent of MACRA by excluding 58% of providers from MIPS requirements for performance year 2019 in the recently proposed Quality Payment Program, or MACRA rule. This will result in 2021 payment year adjustment being around 2% for high performers instead of closer to 7%, which the statute dictates. Last year, CMS excluded 60% of eligible clinicians, which collapsed the potential reward for high performers from 5% to 1.5%. To give you a real-life example of how this works, in the 4 tax identification numbers that Prevea Health bills under partnership with our hospital partners, Hospital Sisters Health System, Prevea Health scored 3 perfect scores of 100 and 1 of 97. However, because of the MIPS exclusions, our payment adjustment was only 2%. Why is this important? To get to value, to create change, is incredibly difficult. It requires changes in how we deliver care, how we set up our administrative and financial processes. It means investing millions of dollars in information technology and people. Importantly, it requires buy-in from every member of the team, especially the providers. The change management challenge presented by creating a new value-based delivery system are enormous. And Prevea Health undertook this challenge because we viewed MACRA as the incentive program that would reward us for making these changes and doing well by our patients. Now, though, I have to go back to the physicians and providers at my group and say the investments we made, they weren't rewarded. The better care we delivered was not recognized. That's a difficult message to deliver, and I don't think that's the message that this committee or Congress wanted us to make, but it's the one we have to tell providers at Prevea because of the way MACRA is being implemented. I appreciate the concerns so ably expressed today by my colleagues for physicians practicing in solo or smaller practices. The reporting burden on them is real. However, I have to point out that the MIPS program is a continuation of quality programs that have been in existence for years, and no one is excluded from these programs, certainly not 58% of them. I firmly believe Congress passed MACRA to push the transition to value in Medicare Part B. Ironically, by excluding the majority of clinicians from MIPS, if anything, we've taken a step back from this transition. These exclusions need to end. Only then can MACRA meet your goal of moving Medicare meaningfully towards value. AMGA stands ready to work with Congress and CMS to ensure MIPS and MACRA serves as the transition tool to value as it was intended to be. Thank you.
Thank you, Doctor. Dr. Parker, you're recognized for 5 minutes, please.
Chairman Burgess, Ranking Member Green, and members of the Health Subcommittee, thank you for the opportunity to provide feedback on MACRA implementation. I'm here today on behalf of the Alliance of Specialty Medicine, a coalition of 15 medical specialty societies representing more than 100,000 physicians and surgeons. My name is Dr. Parag Parekh. I'm a private practicing eye surgeon in rural Western Pennsylvania and the only board-certified fellowship-trained ophthalmologist specializing in cataract and refractive surgery as well as cornea and glaucoma surgery in that entire geographic area. I chair the Government Relations Committee of the American Society of Cataract and Refractive Surgery, one of the Alliance member organizations. The Alliance greatly appreciates your leadership to repeal the SGR, create MACRA, and revamp the legacy quality reporting programs. Listening to physicians' concerns, Congress created MIPS, which streamlined the existing programs and allows physicians to focus on the measures and activities that most closely align with our practices. Successful implementation and long-term viability is important, since MIPS is the only pay-for-performance option for many specialists. We also appreciate the technical corrections advanced earlier this year, which strengthen the law, continue progress made to date, and will improve the ability of specialty physicians to engage in quality improvement activities. MACRA provides 2 value-based reimbursement tracks for physicians under Medicare. Under one, physicians can opt to remain in fee-for-service and participate in MIPS. In the other, physicians can participate in advanced alternative payment models. For many specialists, including ophthalmologists like me, MIPS is the only meaningful and viable pathway. Many specialists have no opportunities to participate in advanced APMs, given that they are designed with a primary care focus. While there is always more work to be done, many specialists have made significant strides to deliver high-quality and efficient care. In the last 50 years, ophthalmologists have made tremendous strides in cataract surgery by reducing complications and the variations in cost. Ophthalmology has developed meaningful outcomes measures, including for cataract surgery, which are being reported through the MIPS program, and CMS proposed to include cataract episode cost measures as well. Therefore, it is critically important that Congress maintain a viable fee-for-service option in Medicare Part B, along with the MIPS program, to ensure that specialists can continue to meaningfully engage in the quality improvement initiatives and deliver high-quality care. The MIPS technical corrections give CMS additional flexibility to determine the appropriate weight of the MIPS cost category, allow CMS to gradually increase the performance threshold before reaching the mean or median standard, and exclude Medicare Part B drugs from MIPS payment adjustments and eligibility determination. However, additional modifications are needed to support more meaningful measures and lessen the complexity of reporting and scoring. Currently, clinicians must comply with 4 performance categories, each with distinct requirements and scoring methodologies. Allowing clinicians to get credit across multiple MIPS categories by engaging in a single set of actions would make the program much less confusing. For example, tracking outcomes through a clinical data registry and using such data to improve patient care should count for multiple categories of MIPS. Alliance specialty societies continue to invest heavily in the development of quality measures, including outcome measures and those reported by patients, and have established robust clinical data registries that have been qualified for use in the MIPS program. In my own specialty, the American Academy of Ophthalmology has the IRIS registry, which serves as a key tool in reporting MIPS data and tracking outcomes. Measure implementation is another ongoing challenge. Our member societies continue to develop new, specialty-focused measures, but CMS threatens to eliminate them when they do not immediately produce enough data to set reliable performance benchmarks. In addition, for more established measures previously developed by specialties, CMS has determined some of them to be topped out and then remove them from the program, even though these measures continue to improve care and continue to be meaningful to specialty physicians. Removing them from the program limits our ability to participate in MIPS. Finally, the Alliance opposes MedPAC's recommendation to eliminate the MIPS program and replace it with the Voluntary Value Program, which relies on population-based measures geared towards primary care and eliminates the one program, MIPS, that specialists can actually use to demonstrate and improve their quality and overall value. The VVP would discourage specialists from developing relevant quality and outcomes measures, disincentivize the use of high-value clinical data registries to track patterns of care, and thwart efforts to collect and report performance data. Again, thank you for your work to ensure successful and timely implementation of MIPS.
Thank you, Doctor. And Dr. Ransoff, you're recognized for 5 minutes, please.
Thank you, Chairman Burgess, Ranking Member Green, and esteemed members of the committee for inviting me to present today. For the last few years, my group, Sansom Clinic in Santa Barbara, California, has been on a journey going from the SGR payment system to become a devoted MIPS provider, only to evolve into a Track 1 Plus ACO. Our journey will provide some insight into what is good and what is less good about the recent shifting of the tectonic plates on which the Medicare physician payment system stands. Before going further, let me tell you about me and my group. I'm a general internist. I've practiced in the same exam rooms for the last 26 years. I've been doing this long enough to recall handwriting my patient progress notes and to have cared for multiple generations of families. I've been able to say to a 70-year-old man, "Your murmur sounds exactly like your dad's did at your age." I've been honored to have practiced for that long in the same setting. Sansom Clinic is a nearly 100-year-old not-for-profit medical foundation with 200 doctors. It is an oddity in that it is not affiliated with a hospital. We have participated in the whole alphabet soup of modern health insurance, from HMOs to PPOs to ACOs. For the last 2 years, I've been the board chair of America's Physician Groups. APG is a professional association representing more than 300 of the nation's most advanced medical groups in the country, many of whom take full financial risk in caring for their patients. With that background, let me return to our story of our journey from the SGR days to being a Track 1 Plus ACO. Whatever criticisms there are about MIPS and MACRA, almost all doctors will say thank you, as all of us have, to Congress for doing away with that flawed process. In the SGR days, our budgeting process was basically chaos. The cut that was generated by the formula would mean that we would be entirely unable to balance our books, so we just ignored it and prayed that the implementation would be put off, as it was every year, usually at the 11th hour. We all sighed a great sigh of relief when the SGR was repealed. Then there was this new process, MACRA, on the scene. Over the last few years, our clinic became a very successful MIPS participant. We got 100, and we made lots of investments in care processes to enhance the health of our populations and patients. And yet we've left MIPS, and we've gone on to become a Track 1 Plus ACO. The details of the journey are included in my remarks, but I'll try to summarize the take-home messages of our journey. What have we learned? The MIPS SGR was really problematic, and though there remains some issues within the MIPS program that need to be addressed, it is far and away a better system than the dreaded doc fix gamble that we all had to rely on for years. The way MIPS has been implemented is not the way it was planned. It is an asymmetric process. The intended large reward for high scorers is gone, but the intended large loss for those who score poorly is still there. Most of that is because so many doctors are excluded from MIPS, more than 500,000 according to the Federal Register. We fully recognize that exemptions are necessary in some cases, but this level of exemptions undermines the spirit of the law and impedes the goal of moving our nation's healthcare system to value. There are real benefits to the patients and to the healthcare system that come from the clinical processes that are put in place to try to do this work well. At the same time, the metrics on which doctors are graded need to be relevant for their specialty and their practice. Here are a few suggestions that we think can encourage the movement from volume to value. Lower the threshold for excluding groups entirely from MIPS, and thereby increase the number of physicians participating in the program. At the same time, in recognition of the fact that smaller groups have fewer resources, MIPS for smaller groups may need to look different than MIPS for larger groups. In other words, give smaller groups a different test, more suitable for their resources, instead of excluding them entirely. Even if there are flaws in MIPS, there is value for individual patients and populations, and importantly, the payer of all of this, the American taxpayer, in encouraging data collection and encouraging the use of and the reporting of high quality and high value care. The processes that are created to do that will help move Medicare from volume to value. We should find ways of making it feasible for more providers to participate in that process instead of excluding them. MIPS can and should be fixed. It should not be discarded. Thank you for allowing me to speak, and I'll be happy to answer any questions.
Thank you, Dr. Ransahoff. I don't see our chairman or ranking member of the full committee back yet, so we'll proceed with the question and answer portion of the hearing. If either the chairman or the ranking member do show up, we will obviously yield to them for their statements as well. And I, again, want to thank each of you for being here, and many of you have mentioned different milestones along the journey that took us from where we were in the early 2000s to where we are now. I will just say, when I first got here, the goal of repealing the SGR became my primary focus. And early on, it was to repeal the sustainable growth rate formula. And I thought if I replaced that with the Medicare Economic Index plus an inflation factor every year, so MEI +1 sounded reasonable to me, pretty simple and straightforward. So that was my original proposal. The Congressional Budget Office threw about $300 billion of cold water on that idea, and I attracted no supporters. And I literally was pursuing that by myself, I think through 2 Congresses. So that's part of what led to the journey where we are now. There were obviously things that hadn't happened along the way. The PQRS, many of you have mentioned, having to come to a conclusion at the end of every year and provide a doc fix. And I don't know how many remember PQRS in 2006 was sort of Bill Thomas's parting gift to medicine, if I can use that term. But PQRS was to pay for the doc fix, right? That's how we got PQRS, and PQRS was one of those legacy programs that now finds itself in MIPS. One of the largest contacts I get on social media is about a new payment rule for labs in Medicare, and I appreciate that it's causing some stress. That is based upon a provision in what was really literally the last doc fix in 2014, a bill called PARMA, that again provided the dollars to bring us the doc fix. So underscoring everything else, the SGR is gone, and we're not having to deal with the doc fix at the end of the year. As I think, Dr. Barkey, you mentioned having to go to your banker every year and explain, well, this isn't really going to happen, right? They say it, but it isn't really going to happen. So that burden also has been lifted, and now that it's no longer there, we kind of forget that it was something that literally it was the end of every Congress, every December of every year that I was here for quite some time. So having provided that background, obviously I'm going to ask the easy question first, and I do want everyone to answer. It's in the tradition of Chairman Dingell. I'm going to make this a yes or no question. Better off today under the system that we have, or were we better off under the SGR legacy? Dr. Barb, I'll start with you. Better off today?
Much better.
Dr. Pelka?
Absolutely.
And Dr.
Better.
Ray?
We are better today.
That's an affirmative. Dr. Perka?
Much, much better.
Affirmative also. And Dr. Ransahoff?
A rare opportunity for 5 doctors to agree.
Okay, I wasn't going to do this, but you reminded me. And then one of my greatest wishes is to someday come into this committee hearing, have 5 doctors at the table who are going to discuss how economists should be paid. We'll save that for another day. This group gets it. The economists don't think that's funny, and I try that on them from time to time. So no program is absolutely perfect, and I appreciate, I guess, Dr. Ransoff, your journey that took you first in the direction of the small practice and then to the alternative payment method. And I will also add, as we were going through the discussions that led to this bill finally getting firmed up, I believed it would take 10 years in this process. And once again, I had a simple formula. Let's do 10 years with a 1% update every year, and that seemed like a good fit. Again, the CBO threw a bunch of cold water on that idea, and it was condensed down to 5 years at a 0.5% update, which actually got a little further lowered after that. But I always thought it would take longer. This is a big change, and more than just having the change and having the bill signed, it's important to get it right. And I hope, if nothing else, this hearing today, and this is the 4th hearing we've had on the implementation of this law, and if anyone at the agency is listening, I want them to understand this as well. It is important that we get it right. It's not important that we passed a bill and that we had a signing ceremony down at the White House. It's important that we get it right, because obviously patients are counting on it, obviously doctors are counting on it, and the taxpayer is also one of the variables in this equation that we have to consider as well. So I think I've heard the answer to this question during your testimony, but I will ask you for the record. Would it be better for Congress to continue to work with the agency, with the Center for Medicare and Medicaid Services, to implement the merit-based system as laid out in statute, or to scrap it entirely and go back to the drawing board? Dr. Barbie, we'll start with you.
We're eager to continue to work on this. We think it has potential.
Thank you. Dr. Palka?
Mr. Chairman, quality is a never-ending cycle. We have to continuously work on this.
That's a great, thank you. I'm going to steal that quote. Dr. A?
I would agree that we need to continue to work with you on MIPS.
I also agree. In business school, they teach us about continuous quality improvement, and I think that principle applies here too.
Sir. Dr. Ransoff?
There's a lot of good to this program, and it should be continued to be worked on.
I have some other questions, and I'm going to submit them for the record. Just one last story about the journey that got us here. There was one morning when he's no longer the majority leader, but the then majority leader came up to me, and I was whining about this problem not having been solved. And he said, well, Doc, wouldn't it be easier if we put everybody into an ACO? Well, the short answer to his question is yes, it'd be easier, but it wasn't the right thing. I appreciate the journey that you've been on, Dr. Ransoff. I think that kind of told me what, in fact, I was telling the majority leader that morning. We're not quite sure about what the journey that different practices will have to take, and it's important for the entire panoply of practices to be able to prosper in the environment. And I'll yield back and recognize Mr. Green for 5 minutes, please.
Thank you, Mr. Chairman, and thank each of you for joining us today. MACRA was an important step forward for our healthcare system, building on the successes of the Affordable Care Act. One of the key goals of MACRA was to further reforms that would promote value over volume and incentivize providers to find new ways to offer more coordinated and efficient care. In order to further that goal, MACRA created the Physician-Focused Payment Model Technical Advisory Committee, PTAC, and to make recommendations to the Secretary for proposals for physician-focused payment models that would help control healthcare spending and improve quality. Dr. Epkla, can you describe why MACRA and the creation of PTAC was so critical to our efforts toward delivery system reform?
I think the key here is, and we really appreciate the congressional action to create the physician input into business models. The care models have changed, and they change every year. They've changed over the last 50 years. The payment model has been stuck from 50 years ago. So we need to take the care model and put a business model on top of it that works, which means that the payer community, particularly in our case, the agency, needs to listen to us and figure out how are we going to incentivize quality? How are we going to reach the congressional goal of value by actually putting a payment model that maps to the care model? And having that relationship, the Congress opened that door, and what we need now is for an agency that's willing to and has the resources to accept that.
Does anyone else on the panel want to comment on how it was working with the PTAC? Yes, sir. Doctor?
Thanks for asking that. As I mentioned earlier, physicians want to be engaged and involved in this process. PTAC was created for that very reason. They have received dozens of proposals that come from the ground level. Physicians that are practicing, that know what will work in their practices and perhaps in their specialty. And yet, none of these have been adopted by CMS, or really, we think, given serious consideration. And these span everything from very focused proposals in GI medicine to reduce rehospitalization in Crohn's patients, all the way up to the end-stage renal disease that could have very broad effect on improving care and reducing costs for dialysis patients. So we think there's great opportunity there if CMS will listen to us.
Any other comments? Which gets me to my point. I want to turn to CMS decision not to test many of the models that the PTAC has submitted for testing. And Dr. Barber, you get the first one. Can you expand on your remarks in your testimony about the Secretary of HHS decision not to implement or test most of the physician-focused models that PTAC has submitted for testing? Why is this so problematic for MACRA implementation?
So the original ideas, these very innovative ideas, were brought forth from the ground level. PTAC was designed to evaluate these, look at the merit, look at the rigor, and make recommendations. And they have not recommended positively on all of these proposals, but they have recommended positively on 10. And again, up to this point, CMS has not seen fit to continue to work on those, to dialogue, to say, well, this is what we don't like or what we do like about this proposal. If you could change it, maybe we could adopt it. They seem to be interested in coming up with ideas on their own. And I think that's not only reinventing the wheel potentially, but it is not taking advantage of some very creative and innovative proposals that have come forward.
Anyone else? Yes, sir, Dr. Epstein.
So, Congressman Green, we did propose to the PTAC. We were early on accepted. We were then accepted in a letter by the Secretary for consideration by the Innovation Center. The Innovation Center had a few conference calls with us and a 1-2 hour in-person meeting from a product that we developed that took almost 5 years in the making. There's no resources and no capability of the Innovation Center to complete a design and then to create an implementation and to have a sandbox or a pilot area in which to test. And so the PTAC has done a fantastic job. The Secretary vetted us, and I think we're the only one that went from the Secretary and was recommended to the Innovation Center, and it died in there because it's just not wired to really innovate, and we really need to turn that on.
Dr. Barbie or anyone else, has the AMA or any other specialty societies received further feedback from HHS or CMS, and why HHS is not testing these models that the PTAC has recommended? Have you had any feedback other than what Doctor talked about?
So we have submitted just a month ago a 4-page letter outlining what we believe are some merits of a few of the very specific proposals that PTAC recommended on up to CMS. And while they acknowledge receipt of those, they acknowledge the work that the PTAC has done, they really have not offered any explanation. As I said, we'd be happy to work through PTAC with them to modify if there was a deficiency they saw in the model. They say the idea is good, but it won't go for this reason. I think we're all eager to work with them. We are 3 years into a 6-year program on this particular issue and still don't have a model that physicians can embrace and use that's been approved.
Mr. Chairman, my time's out, but somewhere along the way, HHS should clarify and have coordination between not just the AMA, but also the specialty societies, because as you know, specialties sometimes are different than a doctor down the road. And but but we need to see what our subcommittee can maybe encourage HHS and CMS to give feedback and coordinate with you on where we're going with this.
I don't disagree. A future hearing that would include both the agency and stakeholders on the PTAC issue seems like a good idea. Chair recognizes Mr. Guthrie, 5 minutes for questions, please.
Thank you very much, Mr. Chairman. Thank you, everybody, for being here. And I know you've touched on some of this in your opening statements, but I know that the 5 minutes is kind of limited, so I want to kind of just go back and give you each a chance to kind of ask. I'll do these two questions together. So my question is for each of you: what specifically have each of you done or doing in your own practices to ideally set yourselves up for success under MIPS? I know you went through MIPS and out of MIPS specifically. And what can physicians do right now to position themselves to succeed in MIPS? And I'll just start with Dr. Barbie. Or then we go right to left since we went the other way. Dr. Rensoff, I'll start with you then. We'll go left.
Thanks. That's an excellent question, Congressman. I'll give an example. We became a patient-centered medical home. We had a long history of capitated care, so we were a very integrated medical group. But going into MIPS, we who were pretty far along decided that we needed to have a culture change within our organization, and so we adopted this PCMH model, which really has changed the way we do things. Our medical assistant, our nurse will, as the patient's coming into the room, will find out, have you had a mammogram that we don't know about? Have you had a vaccination that we don't know about? So we can update it in our system. It's a small thing, but it turns out that that's actually an important culture change because it's engaged us in a much more team-focused approach to care. So that's one example of how MIPS has sort of propelled us along in what we think is the right direction.
Okay, thank you. Dr. Perrick?
Thank you for the question. I would say that there's a two-pronged approach to answering your question. One is on a personal level, and then the other one is kind of our professional society. So within the eye doctor, eye surgeon community, we have, of course, my organization, the American Society of Cataract and Refractive Surgery, and we have the American Academy of Ophthalmology. We work very closely together to develop measures that are relevant to my day-to-day practice and that align very much with what patients want, I think with what you all want, and with what we want in terms of what's best for our patients. So part of it is developing outcome measures, which we have, developing cost measures. It's not an easy task. I personally serve on some of these committees. We spend hours and hours and hours on this, but it's hugely important on a global level to have your professional society helping to create those measures. And then it's like a 1-2 punch almost on a personal level. I tell you, participating in MIPS and getting good scores has not been very difficult. My EMR makes it very simple. I have a coach through my EMR system. We talk regularly, we email regularly. I can keep track of my score of how I'm doing this year. And so having the good measures is very important. And then having a good EMR system and then just the putting forth the personal effort to pay attention to those measures and then improve my deficiencies, become a better surgeon, become a better doctor, and also keep track of those measures. So it's been a two-pronged approach.
Thank you. Dr. Rao?
So to answer your first question, what have we done to prepare for MIPS and MACRA? Really, it is redesigning how we practice. The physician is no longer the center of the healthcare system. The patient should be. And we've redesigned all of our practices, both primary care and specialty care, to put the patient in the middle and establish team-based care, making sure that nurse care managers are interacting with patients, to making sure that if you have a chronic disease, your visit never ends, just how often we connect with you. And we've also made significant investments in data infrastructure. An EMR without the ability to draw the data in is just a really expensive word processor. And we've had to make significant investments in drawing the data out, but then also make significant digital investments that are patient-facing and forward to identify gaps in their care, to establish online scheduling, all of which we've done in this last year. Your other question on what should other physicians do to prepare, and really, it's no longer focusing on the sickness of our patients, but the health of our population. We need to make more investments on keeping people out of the hospital, even out of our clinics, which isn't always financially viable, but we, through MACRA, through MIPS investments, are rewarded for that. And we have to use those value rewards to redesign how we practice medicine.
Okay, thanks, Dr. Lika. I'm about out of time, so we'll go ahead if you got a couple
Well, very quickly, for the most part, MIPS does not measure surgical care. So we do the best we can to help our surgeons get the credit they need for payment purposes, but then we try to refocus them on the quality metrics programs that we have separate from MIPS.
Okay, Dr. Barbie, just one quick thought.
So our group has been very successful, but we have invested heavily over a decade in order to be successful. I'm concerned that some of these programs now simply don't give physicians enough upside opportunity to invest like that in order to be successful.
Okay, thank you, and I yield back.
The chair thanks the gentleman yields back. Chair recognizes the gentleman from Oregon, Dr. Schrader, 5 minutes for your questions, please.
Well, thank you, Mr. Chairman. Dr. Wright, why are 58% of the practices excluded from MIPS? What's your opinion?
You know, I think CMS created those exclusions because physicians felt they weren't ready to participate. But for MIPS to be successful, for MACRA to be successful, there has to be a plus and a negative. It's a budget-neutral program, so there has to be a carrot and a stick. The 58% really came from CMS.
Why are they excluded? Why are they not ready?
Why are they not ready? I think some consider themselves not ready because they've not made the investments or willing to make the investments or take the risk that are involved in now making that transition from fee-for-service to value.
Investments in terms of expensive computers or whatever, or what are you talking about?
I think the investments are multifold. You know, I think probably the most significant investment that we've made is in people, in making sure that we redesign how we practice healthcare. It's in staff. It's not only staff
So
within
it's
a quality
basically a
department.
decision by those offices not to engage, frankly, in the new era of modern medicine, is what.
It is. It's people that would really like to hang on to fee-for-service for as long as they can.
All right, all right. So I guess, Dr. Park, why is MIPS the only option for specialists? Why does, I understand you're not a primary home model type of thing, but why is that the only APM, or why doesn't some other form of APM work for you?
Again, I'll give you my answer, multiple key reasons. First and foremost, most practically speaking, there are no APMs in my area that I could join, even if I wanted to. Sure. So there's just a geographic barrier to that. You will know better than I about the spread of those APMs through the country, but certainly in my area, it's just not a choice. The ACOs are very primary care focused. When I think of how an ACO works and what the potential is to save money and to improve quality of care, it makes the most sense for primary care to be doing that because they're the quarterbacks of the team. You know, they help coordinate the entire ship. My wife is an internist. I mean, we have this discussion at the dinner table all the time. When we in ophthalmology are trying to improve our patients' care, I mean, think of it from our perspective. I'm trying to do a good job on cataract surgery. I'm trying to lower my patient's eye pressure from glaucoma so that they don't go blind. But if we were in a big model, those measures are likely not going to be used. So they wouldn't actually do anything for my patients. They wouldn't actually give me a solid, meaningful measure that I could do. I could measure myself. I could say, oh, I'm deficient. I want to improve. That's not going to exist because the system is so big. So I think we lose something when you have such a massive system. The primary care gets the weight of that in these bigger systems, and I think the specialists are lost. MIPS, on the other hand, gives me a measure that directly affects what I do. I mean, if I'm...
Do you interface with primary care systems at all? Is there any primary care system in your geography?
No.
Okay, all right. In rural Oregon, we've been able to make that happen. You know, so I don't think, I'm not talking to your situation, but just for the sake of the panel and others, there are ways to make APM systems work, ACOs work in rural settings. It just, you know, it's a culture, and after a while, you figure out how to do it like you all are doing as you adopt, you know, new practices and stuff. So Dr. Ransoff, worried about you suggested maybe lowering the exclusion threshold in the MIPS program. Could you elaborate on that a little bit? And to my, you know, investments, I mean, I would assume that the outcomes, whether you're a large practice or a small practice, the outcomes shouldn't really change. You know, if it's patient-centered, you want the patient to be healthy, the less readmissions, you know, less time between surgeries, whatever the option is. Could you talk a little bit about that?
Yeah, I think that the The main issue is just trying to get more doctors involved in the process. The way it's set up now, in a way what you have is you have a bunch of people who are believers, if you will, and are kind of going down that path. And then you have a bunch of people who are just saying, thank goodness this doesn't affect me, and are not making any efforts to change.
Right.
You know, I think that in the absence of change, I don't understand how any of this gets to be affordable. And so I do think there's going to have to be some change. By lowering the threshold from 90,000 to some number less than that, you'd start a gradual transition. People would know it was coming. I do think that, as my colleague here in solo practice points out, I think this is doable. It's just people don't want to do it.
Maybe some sort of
understand that.
phase in with the thresholds so that people can see a path or eventually develop a path going forward.
Correct.
So last question real quick, Dr. Barbie. Everyone's pretty much referenced electronic medical records and EHR, and I'm very, very concerned that while individual practices and groups are making huge investments, originally there was some money from the federal government to help out, gone now. Maybe that's something we should continue or think of, particularly for small practices. But I'm concerned about the system, and you guys have alluded to this, not talking to one another. And there's a vested interest, with all due respect to our EHR developers, to keep that system pretty proprietary and pretty unique so that you got to buy their stuff. Could you talk a little bit about trying to broaden that out? Is there a role for the federal government to require some of these developers to make it easier for doctors to share their information across specialties, primary care, frankly, nutritionists, the whole gamut?
So yes, we believe the Office of the National Coordinator can facilitate better interoperability. Many groups are trying workarounds now, all the way from health information exchanges to other cloud-based. Dr. Opelka earlier referenced activities of the American College of Surgeons. The AMA has significant activities around an IHMI, or Integrated Health Model Initiative, that we believe has some great potential. But all of those are workarounds because the industry has not made data interoperable and, in fact, has blocked data in many cases.
Thank you, and my time's up, but I think that's a critical issue for this committee to address if we're going to be successful going forward. Thank you very much, Mr. Chairman.
Thank you, Dr. Schrader. I would just point out that the third title in the Cures bill that we were planning on having oversight of the implementation was the electronic health records. We did have the mental health title evaluation earlier this week, I think, or was it last week? But in any case, that has been held up because the rule has been stuck at the Office of Management of the Budget, and we had initially planned to have that hearing in June, and it was postponed because of that reason. Then we are eventually just likely going to have the hearing without the rule having been finalized or released by OMB. I'd now like to recognize the gentleman from Illinois, the chairman of the Subcommittee on Energy and Environment, Chairman Shimkus, 5 minutes.
Thank you, Mr. Chairman. It's a great hearing. Tough names out there, so if I butcher them, I apologize for that. For Dr. Schrader, I think we do need to look at this as exemption issue. If this is a movement forward and there's cost challenges, we ought to get everybody on board on the quality bandwagon. So I can't remember who mentioned it in their opening statement, but one of you mentioned that high performers are not getting rewarded. Can you just address that a minute, because obviously you mentioned, I think, correct me if I'm wrong, poor performers are being identified, but high performers not being rewarded.
Yeah, I think both Kurt and I mentioned that. You know, at the end of the day, for the budget neutrality to work, there has to be just as many people involved in this, and that's what the exclusions created. Was the incentive was cut in half for high performers because there weren't as many people in there. The threshold was changed. So from expecting a 4% to a 2% increase, yet making all the investments to value is where we felt that high performers are literally being penalized for making the right investments.
Dr. Ransonoff, I'm going to go with you to the next question too, so why don't you answer that also?
Yeah, we have the same issues. We spent probably half. We'll get a 2.02% reward for getting 100. We probably spent half of that trying to get it. Now, we had done that because we thought that the reward would be significantly more, and it's the right thing to do, but there is an economic issue with it.
And I'm going to talk economics a little bit too, but I want to go back. What intrigued me about your comment to another question was electronic health records or whatever, EMR, whatever you want to call them, asking patients about indices that they may not be there for. We've been dealing with the opioid issue and trying to change law so that there is a little more conversation. As you all know, there are catastrophic stories of the firewall between information, which has turned out deadly. And this whole committee has been trying to do things that we can do to address that. So I applaud that, and hopefully the legislation that we're moving forward, hopefully with the Senate concurrence and the presidential signature, will start making that a little more available. The concern is always going to be data privacy, personal privacy, and the like. So you are the folks in the field, and you're the ones who have to really help us see when you can and help direct us on protection versus sharing of information throughout the practice, especially if we're doing a patient center, as you guys are mentioning, holistic, with different people around. That information has to be shared throughout the practice. So excellent point. I wanted to ask, I wanted to kind of go off, not totally off script, and I'm not trying to get this partisan or political, but in this current world today, how much is, what are you paying in, how do you want to answer this question? I've always been worried about uncompensated care. Even with a government-run healthcare policy, high deductibles, can you talk to me about, and that's all the time I'm going to have, so whoever wants to talk to me about, even in a system where we're doing Medicare, Medicaid, that doesn't pay cost, even if we're moving to high performance. So if we're not paying the cost of care, and then you have folks, and then you're eating uncompensated care, that's where I think our system just breaks down. Anyone talk about uncompensated care? Or charity write-offs, or however you want to define it?
So what the AMA would like to see is no uncompensated care, not from our side, but because that means patients have coverage that will help them get access to care. That's the bottom line here. So it's not a matter of how we handle uncompensated care, it's how do we get more people covered so that they can have access. They don't
quickly,
access.
Anybody else want to jump in? Everybody else is compensated fully and there's no write-offs? That's what you're saying? Or you just don't want to go into this debate right now?
Well, you've opened up a very complex subject matter.
Yeah, right.
The bottom line is that the uncompensated care patients, when they come in to seek surgical care, it's already too late. They're way behind the power curve. And that's the most unfortunate thing. We all see them, we all treat them, we take care of them.
We should take care of them in the internist level or early intervention and provide that care.
Their cancers are diagnosed late, so they have a poor outcome. Let's get in front of the disease, and the uncompensated care patients come in a day late and a dollar short.
My time's expired. Thank you, Mr. Chairman.
Chair, thanks, gentlemen. Gentleman yields back. Chair, recognize the gentlelady from California, Ms. Matsui, 5 minutes for questions, please.
Thank you, Mr. Chairman. I thank the witnesses for being here today. We were talking about telehealth, and a group of us on Energy and Commerce worked together to advance telehealth legislation, legislatively with the administration. As we worked on legislative efforts, we have found that CMS and CBO to be resistant to expanding access to telehealth due to cost concerns. Expansion has often been judged as adding a new service that could be overbilled rather than taking into account that reducing hospital and ER visits would result in better care that could result from getting patients access to care sooner and more conveniently. I am encouraged that CMS has taken steps in this recently proposed rule to expand access to telehealth and Medicare, as this is what we've been working toward. There will be no way to prove success in the Medicare population without covering services. And I'm curious to hear from our witnesses about the types of telehealth services that are they currently implement. Starting with you, Dr. Barb.
Be happy to start. Currently, in our organization, we provide telestroke coverages to rural hospitals.
Okay.
We also are opening up very small cities in Wisconsin, northern Wisconsin, such as Ladysmith, a new site, and we would love to provide more services to there. Some of our specialists live 5 to 6 hours from there,
Right.
but easily could provide follow-up services or counseling services. There's not a lot of times in medical specialties especially, such as endocrinology, that we generally necessarily need to examine the patient. We need to be able to have that conversation and counsel that patient, or other services that are not even physician-based. But unfortunately, we run into the wall with CMS and other payers without an ability to pay for that infrastructure, which does not come cheap. But we have done it with telestroke. We've done it very well. We hope to do more.
Okay, that's great. Anyone else want to comment on that?
So there are many types of services and sites of services
Right.
that are actually prohibited from participating in telehealth or digital medicine. We can start by getting rid of some of those restrictions. We can start by unbundling some of these payment codes so that we can charge differently for consults versus remote patient monitoring.
Right.
My particular group is very robust in what we call virtual care, which is digital medicine, and we put monitoring devices in patients' homes. We'll even run the internet to their home, because in rural southern Missouri, many don't have that. So there are a lot of things, but we can't do this because there is no direct payment. The only reason we can do it now is we're in some risk-sharing arrangements.
All right, anyone else here?
Just very quickly, where there are capitated environments, all these barriers to payment go away, and telehealth actually becomes very creative and innovative. In a capitated environment, in my former practice, we dealt with rural, like was mentioned, but we also dealt with prisoners. And putting telehealth in the prison became a very effective way of getting better care to the prisoner rather than having to transport somebody with all kinds of guards and other security. Telehealth was a savior.
Okay. Let me just go on. You know, one of my legislative efforts with Representative Bill Johnson on energy and commerce is H.R. 3482, which will remove originating site and geographic restrictions on telehealth and Medicare. And the steps CMS has taken to pay for virtual check-ins is very much in line with this idea. We passed a limited version of that bill for opioid services in the House opioids packages, and I hope the Senate will move to take this important legislation. And I really do look forward to having it expand further, and I think that'd be helpful for all of you. I've been working to advance interoperability between electronic health records, and the proposed rule has implemented a performance measurement in order to promote interoperability. I guess, Dr. Opelka, you've talked about this. What success have providers had in working toward a goal of interoperability? Do you feel that the implementation of MACRA has been helpful?
I don't know that MACRA itself has actually drawn attention to this. When we moved away from dealing with the EHRs and we created a patient cloud and we began moving data into the cloud environment in which we could represent information either to a patient or to a clinician from wherever that patient was seen, those models are now emerging separate from the EHR vendors. It is making a huge difference in care in those environments. That's the direction we need to go in, and that's where we need to actually educate the government to help us push incentives that drive us more to a patient cloud environment, rather than to say, this hospital, this EHR, it's this patient and all the hospitals they get care in.
Right, okay. Oh, I think I ran out of time. Yield back, thank you.
Chair thanks the gentlelady. Gentlelady yields back. Chair recognizes the gentleman from Ohio, Mr. Latta, 5 minutes for questions, please.
Thank you, Mr. Chairman. And I want to thank you for the hearing today, and I want to thank all of you for being with us today, because I'm sitting here looking at you, thinking to myself of all the patients you could be seeing right now, and the time that you're taking to testify before us on this important matter. And, one of the great things that we get to do, we travel around our districts, we talk to our docs back home, and we also have the ability to see a lot of the third-year, four-year medical students from our states come through. And, they're working on a lot of, their specialties and everything else, but at the same time, they kind of bring up with all the sundry things that they're going to have to be doing to practice medicine. And I wonder if you all would mind answering a question for me. Just going down the line, if you wouldn't mind. how much time do you take out if you took a percentage that you're practicing medicine or you're doing the administrative side of your job?
I can answer that very precisely. The AMA has done 2 studies, shows that physicians spend about 2 hours in front of their computer screen or doing other paperwork for every hour they have in direct clinical contact. We did a second study that shows for primary care physicians, they spend 60% of their day in non-direct patient care activities.
And it's roughly about 20% of their time doing administrative burden.
You know, it's ballpark around that same number. We at our own organization started to look at EMR utilization after 5 or 6 p.m. when they log in from home after dinner, and how long they're on it. And a significant amount of our primary care physicians are logging in late at night to complete their day, which is definitely leading to a nationwide situation with burnout.
I will echo the comments I mentioned earlier. My wife is an internist, and the kids go to bed around 9 p.m., and we get on our computers.
We've done the same kind of study. We see that internists, it varies somewhat by specialty, but in primary care, it's not uncommon for doctors to spend 20 hours a week after hours doing documentation on the computer.
Well, and I know they're calling votes on us right here. I'm going to ask just one question then. The clinical data registries and the certified EHRs are envisioned by MACRA as serving as critical reporting mechanisms for providers to interact with the Medicare program. Would these represent a decrease in that administrative burden then? We can just go down the line.
They haven't yet. The EHRs still just don't work for physicians. There's too much point, click, move from one field to the next. Even in the certified technologies, which we have, we're still burdened significantly by that.
So the clinical data registries, we run about 7 international registries. They actually pull data in and generate knowledge. And that knowledge is delivered at the moment of care that allows for clinical decision support, that allows for better care, higher quality, et cetera. So while they may take on time, they actually reduce burden and improve patient outcome, so they're very welcome.
I would echo that. The registries are welcome. They help us identify gaps in care that patients may need on an active basis, on a more timely basis, and the ability to access a patient to make sure that we get in front of them before they get in front of us in an acute situation.
As I mentioned in my testimony, the Academy of Ophthalmology created the IRIS registry, and it's been a huge help. I'll give you an example. Let's say 2 days ago I was doing surgery. My EMR records the date of the surgery on the right eye, for example. And then when we see the patient back, of course, we record how the vision is doing. And one of our measures is the patient 20/40 or better within 90 days? So it's an outcome measure, like I said, very important to our specialty, very important to our patients. And so as soon as that vision reaches that threshold, the EMR automatically captures that data. The point is, we're getting outcomes data, and it's very little additional work because the registry is able to grab that info without me typing it in again for the registry. So it's been great.
There's nothing faster than illegible handwriting that is not shared with anyone. And, you know, I've practiced in those days. The computer systems that are out there now are more time consuming. I do think they're much better. You know, I prescribed recently, the patient was on 2 unusual medications and the computer said there's gonna be a drug interaction. And so there are real benefits to it, but it is definitely more time consuming.
Well, Mr. Chairman, my time's expired, and I yield back, and I thank our witnesses again for spending time with us today. Thank you.
Gentleman yields back. Chair thanks the gentleman. Chair does acknowledge there is nothing faster than bad handwriting, particularly if you're left-handed. Chair now recognizes the gentlelady from California, Ms. Eshoo. 5 minutes for questions, please.
Thank you, Mr. Chairman, and thank you to the witnesses. You represent so many that practice medicine across our country and different disciplines, and have headed up and do head up organizations that are representing them. I'd like to go to Dr. Rye and Dr. Ransohoff. with this question. Earlier this month, CMS released a proposed rule that estimated that 42% of physicians participating in Medicare will need to comply with MACRA. So my question to both of you is, with so many physicians that are exempt from both APMs and MIPS, has CMS undermined the original intent of MACRA? Would that be your take? And with so many physicians exempt, will MACRA meet the original payment reform goals it set out to achieve?
I do believe CMS has gone against the intent of MACRA with the exemptions. For this to work, for us to truly move to value, the intent of MIPS, as one of my colleagues has been quoted to say, MIPS was the on-ramp to value. And CMS has created an exit ramp.
Why do you think they're doing this?
I think because change is never easy. The change of going from fee-for-service to value, to taking risks.
Well, we've been doing that for a long time. This isn't exactly something that happened in the last 90 days. I mean, we've been in transition since I first came into the Congress on this thing, and I've been here for a while.
I don't disagree with you at all. The legacy programs did not have the exemptions, and now all of a sudden we're exempting people, and it's truly preventing it's another kick the can down the road. It's becoming SGR 2.0 if they continue that behavior.
Well, how do you think CMS can improve the MIPS implementation?
Implemented it as was written. I mean, really implement
Great.
what you
Good answer.
passed.
Good. All right. Well, that's confidence in the work that we've done, Mr. Chairman. To Dr. Opelka and Dr. Parekh. Is it Parekh or Paresh? Parekh. I've heard from physicians in my congressional district. It's the Silicon Valley district in California. That those in small practice and who practice specialty care face barriers in participating in MIPS. Do you face barriers, as some of my physicians have reported? And if so, what are they?
Thank you for the question. As an ophthalmologist, again, I feel very lucky. We have amazing professional societies. We've been working for a long time, as you said, coming up with measures. I mean, we've been preparing for this moment for a while, coming up with outcomes measures, coming up with process measures, creating cost measures, having a registry. So I'm very fortunate, knock on wood, I thank our professional societies. It hasn't been that hard for us in ophthalmology. And
you know Dr. Chang?
Dr. David Chang.
Dr. David Chang,
yes, he's one of my very good friends, and in fact, he knew that I was coming today and sent me a very kind email. And in ophthalmology, I think our numbers, to some extent, back up what I'm saying. I think people who participated in our registry, I think 85% got a score of 100, getting the 2% that was mentioned earlier. And I think 99% got some type of bonus. So again, we've been working hard at this, very hard at this, and I think it's blossoming.
Would you recommend anything to us that would lessen the burden on physicians so that you can more actively participate in MIPS, or do you think it's just working swimmingly?
I think there's always room for improvement. Like I said, it's a continuous quality improvement mindset that we have to have.
But do you have anything specific? Anyone have anything specific? Sure.
Yeah, so this whole matter of participating or exclusions, if you don't measure what matters, putting money and investments into something that's senseless, nobody wants to participate.
And that's what we're doing?
So all the surgical specialties, all of them, including ophthalmology, the majority of their measures have nothing to do with surgical care.
Wow.
They're measuring primary care. So it doesn't surprise me that primary care says everyone should be in. But it also doesn't surprise me when surgery care says it doesn't matter to the patient I'm treating. So why am I spending money in my practice to send CMS tobacco cessation, immunization rates? Nobody comes to me as a surgeon with breast cancer to talk about those things. We're not measuring what matters. And so as long as we're going to measure silly things, everyone's going to say, I want to be excluded. If you want to measure what matters, put me in. Put me in, coach. I want to play. But that's not what we're getting.
Well, I think that that's highly instructive to us, Mr. Chairman.
That is the reason we are having the hearing.
Yes,
So
well, that's what happens in hearings.
I appreciate
But
your.
what I'm suggesting is that we work with CMS to get rid of what was just described as the, did you use the word silliness? Okay. Thank you to all of you. I mean, you are the healers of the nation. So thank you for what you've devoted yourselves to and taking on the extra responsibility of heading up organizations.
If the gentlelady will conclude her soliloquy, we have about a minute left on a vote on the floor.
I yield back.
And I am going to recess after I acknowledge the presence of Dr. Bustani, former member of Congress, member of the Ways and Means Committee. We appreciate your attendance here today, and we will stand in recess until after this vote.
The committee will come back to order.
Do you mind if I just do it? Or?
Yeah, sure, go for it.
Thank you. There'll be other members that are voting, and we'll be back shortly to ask questions. But we're going to continue the question period. Okay, Morgan's back. Okay, so this is Morgan. You're first. You're not. All right, the chair recognizes Dr. Bashan for 5 minutes to ask questions.
Thank you, Mr. Chairman. I appreciate that, and thank you to all the witnesses for being here. This is, I was a cardiothoracic surgeon before coming to Congress, and this is critically important for our patients at the end of the day, right? And that's what I try to focus on. As you know, the participation in MIPS is low. Everyone outlined. Roughly 60% of physicians are excluded from the program, leaving only $118 million of the $70 billion baseline for incentive payments for practices. Participation in the alternative payment models arm of MACRA is even smaller, with only 5% of physicians enrolled in an APM. CMMI has not approved a single APM submitted from PTAC, and PTAC canceled its June meeting due to the lack of APMs to review. I'm interested in ways to increase participation in and the number of APMs, which is why I introduced the Medicare Coordination and Improvement Act, HR 4206, which 3 of you on the panel's organizations have signed a letter in support of, and I'll get to that in a minute, which would encourage development, testing, and participation in APMs by exempting practices from the volume and value prohibitions in Stark law. After all, how can practices deliver on value-based care if they cannot remunerate their physicians based on value? So the letter, and Mr. Chairman, I ask unanimous consent to submit the letter to the record.
Without objection, so ordered.
The American College of Surgeons, the American Medical Association, and AMGA, amongst many others, have signed on to the letter, and basically it says they're in strong support of the act that we introduced, and the legislation would substantially improve care coordination for patients, improve health outcomes, and restrain costs by allowing physicians to participate and succeed in alternative payment models. The bill would modernize the Stark self-referral law enacted nearly 30 years ago. The things that it would do is provide HHS with the same authority to waive the prohibitions of Stark law and associated fraud and abuse laws for physicians seeking to develop and operate APMs, as was provided for ACOs in the Affordable Care Act, remove the volume or value prohibition in the Stark law so that physician practices can incentivize physicians to abide by best practices and succeed in the new value-based alternative payment models. This protection would apply to physician practices that are developing or operating an alternative payment model, including advanced APMs, APMs approved by the Physician-Focused Payment Model Technical Advisory Committee, MIPS APMs and other APMs specified by the Secretary, and finally ensure that CMS's use of current administrative authority promotes care coordination, quality improvement, and resource conservation. I guess I'll ask the question of everyone. How do you think changes to the Stark law to help physicians coordinate and improve care and help MACRA succeed, and how important do you think that would be in the overall success of what we're trying to do with the MACRA legislation, and also, as you have noted, transition to for an outcome-based, patient-centered based way to reimburse providers? I'll just start that in. If any of you aren't aware of what we've done, that's okay, but we can start with college surgeons.
Thank you very much. First of all, yes, we are in strong support of this effort. Specifically to Stark, the way that Stark is written, you can be held accountable without intent, and that's a problem. So when we have alternative payment models with shared savings opportunities between all the parties, legal counsel, when they review these contracts, become extremely worried about how clean are these waivers or exemptions from Stark. They've got to be bulletproof because Stark is so broad and overreaching, it is easy for a court to interpret things differently than your own counsel interpreted them. For that reason, when we go to these alternative payment models where there are parties that will be involved in shared savings or whatever different payment models are applied, we need to be sure that there's clean, crisp lines that exempt or waivers that are provided for Stark so the parties can come together. And that's really what we see. When we put our own APM forward to PTAC, we included the need for Stark waivers and exemptions, but we agree with you and fully support what you're doing.
In order to have a ACO, particularly an ACO like this that requires risk-taking and risk-sharing, you need to get a group of physicians together who are willing to work together and share the risk, and also generally a hospital. So you need all of those parties to do that, and then these laws become a serious impediment to doing that. Just the legal expenses of trying to make sure it's even okay to have a meeting become daunting. So I think if you're gonna encourage doctors and hospitals to try to take risk together in the fee-for-service world, you do need to look at the regulatory barriers that exist.
All right, thank you. Anyone, and to beg your indulgence, Mr. Chairman, anyone else have any comments quickly? Anyone else?
Stark made sense in a fee-for-service environment, but if we're truly going to move to value, we need regulatory relief, as explained by my colleagues.
Okay, thank you. I appreciate that. Thanks, Mr. Chairman. I yield back.
Thank you. The gentleman yields back. The chair now recognizes Mr. Griffith of Virginia. 5 minutes for questions.
Thank you very much, Mr. Chairman. I appreciate you all being here with 2 vote series disrupting the committee. It's tough as witnesses, and I do appreciate your patience. Let me echo what my colleague just said about the Stark Act. I think it's outdated probably in more ways than most people do, and I find it inhibits some collaboration in rural areas where we're underserved already, and why would we put barriers up? Does anybody disagree with that statement? I'm looking at the entire panel just for the record. None of them disagrees with that statement. All right, let's see. Given that, and now I've got a question that we want to get on the record. On June 29th, CMS allowed MIPS participants to see their performance score based on 2017 reporting. Would each of you please share what your scores were?
I'd be happy to start since I brought mine with me.
All right, that'd be fine.
We bill under 4 tax ID numbers because of how we're regionally divided. 3, we scored 100, and on the 4th one, we had a 97.
Okay. Anybody else weigh in who knows? Yes, sir.
I like your question because it also relates to the previous issue of physician participation. I was in a big group practice, and I decided to start my own practice. And so it was end of 15 and into 16 that I was doing that. The 2017 measurement, which you're asking about, is based on your surgical volume or your volume at the end of 16. But that's when I was starting my practice. I knew, of course, about our Academy's IRIS registry. I knew myself. I knew that I could do a good job on those measures, but there was no opportunity for me to participate. I couldn't opt in. I couldn't believe that I couldn't opt in, so I asked multiple people. I'm like, are you sure I can't opt in? I would love to do this. This is great. It's a good measure. Multiple people assured me I could not. So unfortunately, I was not eligible, even though I wanted to be.
All right.
As I've said before, we bill under a single tax ID number, and we did get 100.
Okay. And last but not least.
I'm retired from practice, so I'm
so
dodging it.
no data. All right. I appreciate that. Thank you so much. My concern, of course, is rural areas, as I mentioned before when I was talking about the Stark Act. So when we're looking at rural areas, can you describe or can any of you illuminate us on the challenges of physicians practicing in the rural areas and the pressures they face to remain in practice, and how did the legacy programs add to those burdens? I mean, I know a lot of the burdens they have already, but how did the legacy programs add to those burdens? And has MIPS eased those burdens? And even if it's eased them a little bit, what else can we be doing to help our rural friends? Go ahead, Dr. Barbie.
Maybe I'll weigh in on that first. So I was amazed when MACRA passed and we were looking at MIPS, and we had a lot of physicians come out of the woodwork and say, oh my gosh, how are we going to comply with MIPS? And I thought in my mind, well, have they not been doing the legacy programs already? And the answer is no, they hadn't. Hundreds of thousands of physicians didn't participate in all 3 or didn't participate successfully. So there are a lot of physicians that are now working to make this transition. Specifically with regard to rural, Dr. Opelka said it very well. We need meaningful measures that relate to that individual physician's practice. We need to make them easy to capture, and we need to make them, if you will, activities that are applicable across more than one of those dimensions of MIPS. If you've got a diabetic patient and you're changing your processes and you're improving care and you're using electronic record, why don't you get credit across all three domains?
All right. Yes, sir.
Very quickly, the trauma program is a classic example where we have level 1, 2, and 3 levels of service. Typically in the rural environment, we're dealing with the level 3. The number of standards they need to meet are significantly less than the 200+ standards for a level 1. So you need to tailor measurement down to the point of care and the care model that that environment has. The MIPS program does not do that. It's a one-size-fits-all program. So the rural element is no different than in surgery, is no different than in the city. They're not meaningful and fit for purpose. And therefore, the surgeons pay attention to it for purposes of payment, but not for the purposes of quality of care.
Okay. Anybody else?
We
Yes, sir.
operate many rural clinics, but because they're part of a larger multi-specialty group, we're able to spread our infrastructure more efficiently to them. And to your other question about was it easier under MACRA to submit versus the legacy programs, I have talked to our quality department. It was slightly easier this year to submit to CMS. The mechanism of submitting all three at once was easier than the previous legacy format.
So it's a little bit better.
A little bit better.
Yes, sir.
I would echo all of these comments. Understand that rural medicine is very different than urban, suburban. And I know Washington, oftentimes people talk about a bubble in Washington, but coming from central Pennsylvania, it is a very different environment here. I mean, let me tell you, there are hospitals where I can't get internet service. I mean, just think about that statement. And my EMR, of course, is a cloud-based EMR. I mean, this is a true issue. But again, I think MACRA has certainly helped to answer the second part of your question.
Yeah. And other parts of our committee are trying to work on those internet issues. Dr. Razanoff?
I mean, technically right now, for someone who had just done nothing, MIPS is actually better just by the algebra of it initially because the cut would have been less. But I agree with what my colleagues and I've said previously. I think for small practices in rural areas, they just need a difference. They need relevant standards that resonate with their practice, but they probably need to have a different test so that they can participate. Fewer measures, I think, would be a very reasonable approach.
All right. Thank you very much. I appreciate it, and my time is up, and I yield back.
Thank you. Gentleman yields back. The chair now recognizes Mr. Carter from Georgia for 5 minutes for questions.
Thank you, Mr. Chairman, and thank all of you for being here. Before I begin my questions, I have to say this. Earlier in the hearing, there was a conversation about doctors' handwriting, and I just want to say, I want to represent my profession as a practicing pharmacist for over 30 years. So you get it. You understand what I'm saying. Anyway, I couldn't resist that, and I apologize. Too many times have I struggled to understand what a doctor was writing. I wanted to talk to you, Dr. Rai is, okay, I'm sorry, I know I butchered that, but nevertheless, I'm a member, as a pharmacist, I'm a member of the Doctors Caucus, and we had sent a letter to CMS earlier this month about MACRA and MIPS implementation and the $500 million that had been authorized to ensure positive payment adjustments. But one of the things that we've run into is that we just don't have enough physicians who are participating. And I just wanted to ask you, CMS estimates that it's over 60% that aren't participating. What are the obstacles, and what are some of the obstacles that are preventing or prohibiting providers from switching to this?
You know, I think some of the obstacles are inherent to how they've been practicing medicine and how their own structures have been developed over time. Some may say they've not, followed the legacy programs as was mentioned earlier, so they've not actually implemented the EMR or using it in a meaningful way. They've not developed, patient-centered medical homes or have the ability to tap into registries. There are a variety of reasons why people are not participating, but for us to truly move to value, we need everybody to participate. MACRA was written to be a carrot and a stick program. So for it to work, everybody has to be in.
I suspect that I would be correct to say that it's worse in rural areas than it is in urban areas. Is that correct?
You know, I haven't seen CMS's distribution of who's not participating, but I think it's across the board. I think you'll see it in small single specialty in a very urban area, but yes, you'll probably see it a lot in urban areas that don't have a system infrastructure supporting them.
Okay. Can you describe very briefly about some of the investments that your organization has made in order to participate in this?
I probably think I can break the investments into three categories. The first being people. The most important category in healthcare is continuously investing in people. Team-based care is not inexpensive. Nurse care managers, extra medical assistants, making sure the physician or the provider is surrounded by the best people to take care of their population, not just the patient that's in front of them that day. The next area is, like I mentioned, an EMR is only as good as you can draw the data out of. So our largest area of investment in the EMR is not really the EMR anymore. It's digital platforms to draw the data out, to analyze it, to hopefully someday get access to claims data, which we need, to be able to look at a risk population and predict what's going to happen to a patient before it happens to them. And the third area of investment is that digital platform that's patient-facing. Our patients want access to their record. It's not our medical record, it's their medical record. It's creating environments for them to interact with us in virtual care like we launched this year, where they don't have to come into the office. Those have been the three categories of investments that we've personally made to make sure we're successful, not only with MACRA, but with value down the line.
Great, thank you. Dr. Parikh, I wanted to ask you, in your testimony, you had mentioned that MedPAC had made the recommendation that MIPS should be replaced with a voluntary value program that might be phased in over time. And I just wanted to ask you, in full disclosure, I agree with you that I don't agree with MedPAC. I think that would be the wrong route for us to go. I think we're headed in the right direction with this. We got to figure out a way, I think, if not to incentivize, then to require physicians to do this. I mean, and I don't like that. I don't like the heavy hand of government, particularly in healthcare. But at the same time, I'm convinced we're moving in the right direction. I just wanted to ask you, what are some of the challenges to developing outcome measures in the practice of medicine?
It's just hard. It's hard to do. You have to have a clean measurement. You don't want all these other comorbidities that are, quote unquote, messing up your outcomes. So let's take cataract surgery, for example. If I have a patient who's got severe blinding macular degeneration at baseline, and then they've developed a cataract on top of that, as bad as their vision was, now it's worse. So I take their cataract out, and I get them maybe to 2400, which is, the big E, legal blindness still. They are ecstatic, but my measure might look bad because, oh, Dr. Parikh, this patient, you operated on them and they're legally blind. So things like that, those subtleties, the devil is in the details, right?
Right.
Those subtleties make all the difference. So coming up with those kind of clean outcomes are very hard to do. And so there are certain surgeries that lend themselves to that, but others that don't. And
Well, I'm out of time, but I want to thank all of you for your efforts in moving this forward, because I do believe we're headed in the right direction with this, and I yield back.
Thank you. Gentleman yields back. Seeing there are no further members wishing to ask questions, I'd like to thank you all for being here today. As somebody mentioned earlier, they're missing a lot of patients today to be here to inform us, but it's important that you do. And I'd like to submit some following documents for the record. American Academy of Dermatology Association, letters from American Academy of Family Physicians, American College of Physicians, Connected Health, American Society of Clinical Oncology, Infectious Disease Society of America, and Medical Group Management Association. Without
No objection, Mr. Chairman.
So ordered. Pursuant to committee rules, I remind members that they have 10 business days to submit additional questions for the record, and I ask that witnesses submit their response within 10 business days on receipt of the questions. Without objection.
Mr. Chairman, I'd just like to recognize a family from my district, the Garcia family, who we spend a whole lot of time in these committee meetings, but thank them for coming here.
Welcome to Washington. Thanks for being here. So without objection, the subcommittee is adjourned.